Hello everyone, this is Roy Stroud with the Department of Neurology, and I'm here with a summary video on our clinical reasoning in neurology case number 1. Our patient who came presented with evaluation or presented for evaluation of falls and who was found to have a Parkinsonism. You all have done a great job on this case, and both the localizations, the categorizations and classifications, as well as the differential diagnoses and evaluation plans that you have set forth are excellent for this case and this patient. And so I will ask the group to turn and reflect on all of the great information that you all have provided about this case and this common presentation. I'll take the next 10 minutes or so to review some of my thoughts and give you some final words and hopefully some tips and tricks for how to evaluate these patients. So Parkinsonism, the number of things that can cause a Parkinsonism are quite many, and this ranges from the chronic progressive degenerative Parkinsonisms like idiopathic Parkinson's disease, as well as the Parkinson's plus syndromes, which we know to be progressive supranuclear palsy, multiple systems atrophy, which folks have mentioned, as well as this thing called corticobasal degeneration or corticobasal ganglionic degeneration. We also know that there's a variety of other things that can contribute to a Parkinsonism, right? There's drug-induced Parkinsonisms, and we learned one of those potential agents, metoclopramide, as well as the atypical antipsychotics. We know that normal pressure hydrocephalus, which was brought up, can cause a Parkinsonian-like picture with a wet, wacky, and wobbly patient, wet incontinence, wacky dementia, and wobbly ataxia, that triad for normal pressure hydrocephalus, though Parkinsonism, rigidity, and bradykinesia can also be prominent features. And then there are a variety of other things that can affect the basal ganglia. Carbon monoxide poisoning can affect the basal ganglia. Manganese toxicity is a toxic or metabolic condition which can affect the basal ganglia. Lupus cerebritis has some predilection for the basal ganglia, as well as antiphospholipid syndrome are some inflammatory things that can affect the basal ganglia. And the list is even longer than this, and so the number of things that we see that can affect the basal ganglia and present as a Parkinsonism is quite vast. And so what I want to go through is take the next, again, about 8 to 10 minutes to walk through one way to organize this large differential, this large list of potential diseases that can result in a clinical presentation of Parkinsonism or falls and can affect the basal ganglia. And so here it is. Here is my concept map, a one-slide summary of how I might organize Parkinsonisms and Parkinsonian disorders. And there's a lot of information on this slide, and I want to spend the next few minutes going through each of the aspects and walk you through one way of organizing this information. So first, what is a Parkinsonism? What do we mean by this word Parkinsonism or Parkinsonian? Well, really we mean these symptoms that are outlined here on the left, and there are several cardinal features, clear signs or symptoms that suggest that the problem lies in a certain area of the brain, and that is the basal ganglia. And there are also some associated supportive features that, while not cardinal, while not requirements or necessities for determining that the problem lies in the basal ganglia, are highly supportive of this. So what are the 4 cardinal features of problems from the basal ganglia, of problems that we will henceforth call Parkinsonian? Bradykinesia, number 1. 2, rigidity, and these are probably the 2 most important. If I had to rank these, really 1 and 2 would be the 2 primary symptoms or primary features. Bradykinesia being slowness of movement, and that can range on the order of from akinesia, absence of movement, to bradykinesia, which is simply just means slowness of movement. Rigidity, and rigidity is a type of increase in tone. There are 2 types of increased tone. Oops, I've crossed that out there. There are 2 types of increased tone. One is rigidity. That is increased tone that is independent of velocity, independent of angle, And we call that lead pipe. And the reason we call that lead pipe is a lead pipe is stiff and rigid no matter how you bend it, no matter how fast you bend it. And the same is true for the increased tone that we see from pathology arising from the basal ganglia. This is in stark contrast to spasticity. And spasticity is also increase in tone, but it's increase in tone that is velocity and angle dependent. The faster you move the arm or the leg, the more tone that is felt. The more the arm and leg or the joint is moved out in extension at extreme angles or large angles, the more that tone is felt with that passive range of movement. In it flexion and with slow movement, spasticity the tone tends to be less. So there are two types of increased tone. One is rigid tone, that is velocity and angle independent. One is spastic tone, that is velocity and angle dependent. Rigid tone comes from problems arising from the basal ganglia, and so this is an extrapyramidal symptom, whereas EPS, extrapyramidal, whereas spasticity is a pyramidal system. This is a problem that arises from the primary motor cortex or the circuit all the way down to voluntary motor control. So primary motor cortex, internal capsule, the radiations, and cerebral peduncles into the pons, the pontus basalis, that ventral aspect of the pons, down to the pyramids in the medulla, and then decussating to descend in the corticospinal tract. Spasticity comes from a problem in that area. So those are really the two cardinal features of a Parkinsonism. If a patient presents with rigidity and bradykinesia, the first thing on your mind should be Parkinsonism, and if we're dealing with a Parkinsonism, the first things that we're going to think about are bradykinesia and rigidity. Postural instability, really retropulsion, tested by the pull test on exam, is another key feature of pathology arising in the basal ganglia. And tremor, though it does not necessarily come from the basal ganglia proper, is also an important cardinal feature in this grouping of symptoms, this constellation of symptoms. So any patient that presents with bradykinesia, rigidity, postural instability with or without tremor, we are going to call that a Parkinsonism, or we're going to call those Parkinsonian features, and we're going to head to the basal ganglia to look for that problem. Whenever there is problems arising from the basal ganglia, we will look for bradykinesia, rigidity, postural instability with or without tremor, because those are the symptoms and signs that arise from pathology in that area. There are also some non-cardinal but supportive features of a Parkinsonism: micrographia, which is simply slowness with writing; mass facies, which is simply slowness of the movement in the muscles in the face; constipation, slowing in the gut; orthostasis, slowing of that autonomic response to standing; the vasoconstriction that occurs; erectile dysfunction, another autonomic symptom that can be seen with pathology in this area; shuffling gait and falls, again hitting on the slowness; camptocormia is a change in posture. It's a very stooped, bent posture that we can see with some of the Parkinsonisms and REM behavior disorder, acting out dreams. It's the loss of atonia and during REM sleep. So the presence of tone, the presence of the ability to move during REM sleep. So some supportive features. You put all these together, and patients presenting with these symptoms will henceforth be labeled as having a Parkinsonism, a problem that arises in the basal ganglia, and will head to the basal ganglia to look for that problem. But as we discussed on the first slide at the beginning of this talk, there's a lot of things that can affect the basal ganglia. There's idiopathic Parkinson's disease, the Parkinson's plus syndromes, normal pressure hydrocephalus, drug-induced Parkinsonism, vascular Parkinsonism, and a range of inflammatory, infectious, toxic, metabolic, and paraneoplastic or neoplastic conditions that can affect this region of the brain. So how do we sort through all these? How do we arrive at an organized structure, a way to group our questions and our physical exam maneuvers to hone in on one specific area? And so to do this, I would argue, and I would ask, and I would challenge you to organize this in three ways and ask three questions of your patient, of the presentation, to try and parse through where this condition may be arising. And so when we start to break the Parkinsonisms down into a group of questions, our first question is going to be the timeline. Is this something that started acutely? Is this something that started subacutely? Is this something that's been more chronic? Our second question is going to be, Is this levodopa responsive? Levodopa, synthetic dopa analog that crosses the blood-brain barrier. Is this something that is levodopa responsive, or is it not responsive or poorly responsive? The response is incomplete or non-durable. And then the last question is going to be, what's the symmetry of this? Is this a Parkinsonism, rigidity, and bradykinesia that is particularly symmetric? Or is this something that's more asymmetric and affecting one side of the body or the other? So we're going to work through each of these questions and work through this complex list of potential conditions and hone into the specific single or group of conditions that may be contributing to our patient's pathology. So the first thing to think about with this patient who presents with rigidity, bradykinesia, postural instability with or without tremor is, what's the timeline? And here I've sort of parsed through the potential timelines that we're going to see, and one is a condition which is chronic and progressive, and the second will be something that's more subacute in onset and presents more quickly. So what are the chronic Parkinsonisms? Well, those are the things that we classically think about and are classically taught, and that is idiopathic Parkinson's disease, the Parkinson's plus syndromes, which is progressive supranuclear palsy, multiple system atrophy, and corticobasal degeneration, and then those things that are in that similar spectrum: normal pressure hydrocephalus, a chronic appearing disorder; drug-induced Parkinsonism. Parkinsonism from a drug tends to be a late effect, a more chronic effect, and Parkinsonism or Parkinsonian symptoms that arise out of a dementia or a primary cognitive disorder, and then the vascular Parkinsonisms, multi-infarct Parkinsonism or Parkinsonism from chronic microvascular ischemia. So all of those present chronically. So the first question is, what's the timeline of onset? If this is chronic, we're thinking about these conditions. If it has been more of a subacute progression over the course of weeks or only a few months, then we start to think about those disorders, those pathophysiologic processes that present more subacutely, and we think about inflammation, and we think about infection and paraneoplastic conditions. There are some rare degenerative conditions, a rapidly progressive Parkinsonism, which can present more subacutely, but what I want you to think about is those classic conditions, those classic types of processes that present more subacutely. And the only thing I've left out of that is toxins and toxic metabolic processes, and this really splits the line. So there are some toxic processes that present more subacutely, or even near acutely. Carbon monoxide poisoning would be one of those. There are some that present more chronically, manganese toxicity and some of the other, Wilson's disease kind of splitting the middle of those that present more chronically. So toxic metabolic conditions, as we know those conditions to be in general, toxins can build up in the body and result in a subacute presentation, or they can build up slowly over time and present more chronically. But our first question in working through this complex list of conditions is, what is the timeline of onset? Is this more of a chronic process, or is this more of a subacute process? And so with timeline of onset, we're starting to narrow the number of conditions down to something that's manageable, and we move to our second question. And that really is most pertinent for the chronic conditions. So if we think about idiopathic Parkinson's disease, the PD plus syndromes, drug-induced Parkinsonism, normal pressure hydrocephalus, the dementias, as well as vascular Parkinsonisms, those chronic progressive Parkinsonisms, a DOPA challenge can be a very effective way for parsing through these conditions. We know that there is really one chronic progressive Parkinsonism that is levodopa responsive, and that's idiopathic Parkinson's disease. That's one of the hallmarks, the classic classic features of idiopathic Parkinson's disease. This tends to be an asymmetric Parkinsonism that starts on one side of the body, often with prominent tremor, though it does not have to be. There are akinetic, rigid types of idiopathic PD, and classically it is there is observable and measurable, quantifiable clinical response to levodopa, which is durable and can last for months and often years. So the levodopa responsive Parkinsonism, chronic progressive Parkinsonism, is idiopathic PD. If this Parkinsonism, this chronic progressive Parkinsonism, is not levodopa responsive, then we really move to the other side of this line here, and we're thinking about the other things on our differential for a chronic progressive Parkinsonism. The Parkinson's plus syndromes, which are the exact same things as idiopathic PD plus some other symptom in a levodopa non-responsive or poorly responsive patient. And there are really three Parkinson's plus syndromes: progressive supranuclear palsy, rigidity, bradykinesia plus vertical gaze palsy. and a prominent axial rigidity. There is multiple system atrophy, rigidity, bradykinesia, plus early autonomic dysfunction, early orthostasis, early erectile dysfunction, multiple system atrophy, Parkinsonism, plus prominent autonomic features. And then there's a corticobasal degeneration, Parkinsonism plus, in other words, rigidity, bradykinesia, postural instability, plus early onset asymmetric apraxia. So this is both cortical and basal degeneration, basal ganglia degeneration resulting in the Parkinsonian features, and cortical degeneration, particularly of the parietal lobes, resulting in apraxia. Apraxia can even become to the point where the limb becomes alien, and it is so the body and the brain is so neglectful, so extinguishing of one side of the body that it appears alien limb syndrome. So there are three Parkinson's plus syndromes, and these are characterized by a chronic progressive onset, lack of Synomet response, lack of levodopa response, plus some extra symptom, and that is either early falls with vertical gaze palsy, progressive supranuclear palsy, that is early autonomic dysfunction in multiple system atrophy, or asymmetric apraxia in corticobasal degeneration. And then there are a few other things that fall into the list of chronic progressive Parkinsonisms that are levodopa poorly responsive, things like normal pressure hydrocephalus, drug-induced Parkinsonism, the dementias and vascular Parkinsonism. And so there is our third question, one other way to begin to differentiate between these other things that fall above this list of the sort of classic chronic progressive Parkinsonisms. And we'll get to that in the next slide. And so again, we're slowly starting to whittle this long list down into a manageable number of conditions. We first use the timeline of onset. Next, we either chronic or subacute. We next use the levodopa response, either favorably responsive or less responsive for many of those chronic progressive Parkinsonisms. And the last question we can ask is, what is the symmetry of this condition? Is this something that began on both sides of the body with tremor in both sides of the body, bradykinesia, rigidity on both sides of the body, in which we would favor it being a more symmetric condition, or did this start highly asymmetrically? One side of the body was affected clearly before the other, and the other side is not involved or becomes involved over time. And if you think about this with the conditions that we've already discussed, idiopathic PD tends to be asymmetric in onset and then progresses bilaterally. The Parkinson's plus syndromes, the PSP and MSA tend to be a little bit more symmetric than corticobasal degeneration, which tends to be highly asymmetric. And so symmetry can become important in these more frequently encountered or more frequently considered chronic progressive Parkinsonisms. In addition, it can become helpful for those that fall in this area. So normal pressure hydrocephalus and drug-induced Parkinsonism tend to be more symmetric. The drug affects the whole body, muscles and brain cells all over the body and brain, and so drug-induced Parkinsonism, as well as NPH, a diffuse ventriculomegaly, a diffuse pressure and volume problem within the brain and spinal fluid, tend to be more symmetric presentations, as well as maybe Lewy body dementia. In contrast, vascular Parkinsonism, a stepwise, progressive, often asymmetric Parkinsonism, tends to fall in that more asymmetric category. So symmetry becomes important in parsing through this differential and narrowing things down to about one or three things. When we move up to the subacute category, these subacute Parkinsonisms, it becomes less satisfying, and while there are both inflammatory conditions that can present somewhat symmetrically, there are also those that can present somewhat more asymmetrically. There can be infections that often are somewhat more symmetric, but certainly those that are asymmetric. Toxo, often unilateral basal ganglia dysfunction. Cryptococcus often causes a meningitis, so it can be bilateral, but doesn't have to be symmetric. Paraneoplastic anti-MA1-2 antibody syndrome can affect the basal ganglia and hypothalamus-thalamus, but is often not strikingly symmetric, and then the same goes for some of these toxic conditions. So symmetry starts to help us a little bit, many of these being asymmetric, though there are symmetric presentations for the subacute category, but certainly in the chronic progressive Parkinsonisms, that symmetry can be exceedingly helpful. And so to conclude, when we approach this case of a patient presenting with a chronic progressive Parkinsonism manifesting in falls, we first turn to our 4 cardinal features of a Parkinsonism and ensure that we are dealing with chronic progressive falls arising from the basal ganglia. We can use some of these supportive symptoms to help confirm our suspicion, and then we walk through our 3 key questions. What is the timeline of this condition and its onset? Is this something that we find to respond to levodopa or a dopa challenge? And how about the symmetry? What's the symmetry of this condition both in history and on exam? And we take this list of many conditions, many things that can result in basal ganglia pathology, and start to narrow them down to 1 condition, idiopathic PD, a handful of conditions, the Parkinson's plus syndromes, or a number of acquired conditions, in which case our further evaluation by either imaging or laboratory tests can narrow it down even further. So thanks for your time and your input on this case, and look forward to your feedback.